Thanks, Stuart. And thank you, Chucky. I appreciate it, and I appreciate the opportunity of being out here today. I'm going to bring 3 other people out. We're going to talk to in just a minute. They can come back out on the stage when you're kind of ready to go. But I was talking to folks about what I'm going to talk about this morning, and I decided I would do it really as a panel with 3 of the experts who really know more than I do about kind of what's happening. But I wanted to give you a little overview of what I call the changed face of telemedicine. I call it the changed face because it's already happened. This is not something that's happening. This is stuff that's already happened. For the last 6 months to a year, I've been talking to CEOs of a lot of companies and a lot of medical institutions all over the country. And it's been interesting that I've found some very common things, and there's some things that I've seen has really changed. And as I say changed, when Walmart put in its 3rd or 4th store, retailing has already changed across the country. It wasn't something that was in the process. By the time CVS put on its 10th store, pharmacies had changed. There was no longer the pharmacies the way we looked at it. It may not have hit every community in every small town or every big city, but it has changed. The same thing with Borders. When Borders and Barnes & Noble put in bookstores, retailing had changed for books. And of course now they've changed because of Amazon. It's all in the process of change. Telemedicine has changed. It may not have changed in every community. It may not have changed in every small town. It may not have changed in every hospital. It has changed. The face of it has changed. It's changed in 2 ways. First, what I call the Walmartization of healthcare. The Walmartization of healthcare. Atul Gawande calls it Big Med. If you read his articles, he just had one in New Yorker not long ago. And what do I mean by that? Well, I'll give you an example. Mayo Clinic. Mayo has something called the 200 million lives. They're going to touch 200 million lives. That's their goal. That's about 2,000 times the people who live in Rochester, Minnesota, so they're probably not going to expand their hospital. They're actually expanding throughout the country in affiliations, developing a Mayo network, and doing something that they like to call e-consults. I like to call it telemedicine, but they call it e-consults, which is fine. So they're going to be out in every community. They're moving all across the country. That's Walmartization. Cleveland Clinic has about 9 facilities or 9 networks that they're opening up. They're opening not only in northeastern Ohio, they're in Florida, they're in, I don't know if Ed Brown's here yet or not, they're in Toronto. They're even in overseas. In Panama, there's about 170, 180 bed hospital. That's a Cleveland Clinic hospital. They're all over the place. We are moving ahead very fastly with a change in the way healthcare is provided, and they're using telemedicine as a way to provide these links and a way to move out. Telemedicine has gone from the idea of having a grant to into the CEO's office. And when the CEO takes it, it's because they see this as a major important business plan. People have said there's about 90 different major health systems in this country. Their projection in about 10 years or so is that we will have maybe 15 major health systems serving this country in a conglomeration of networks upon networks that will happen throughout the country, all linked together through telecommunications. So that's the one thing, is the Walmartization. The second thing is what I call the new kids on the block. Joseph Schumpeter, who is the old economist from 100-some years ago, who was one of the kings of innovation, talks about with innovation, you don't have the old companies start doing new things. You have new companies doing things beside the old companies. You don't have the stagecoaches creating railroads. You have railroads coming up. Well, it's not surprising we're seeing the same thing in telemedicine and generally in healthcare. So we have the new kids on the block. It started years ago, actually, with radiology. So now radiology is pretty much throughout the country, and a lot of hospitals are outsourcing their radiology. Well, it's not surprising. All of a sudden now we're seeing it in neurology outsourcing. We're seeing it in psychiatry. We're seeing it all over the country in a whole variety of activities. And also with the new kids on the block, we're seeing new players in the healthcare market. We're seeing online service providers that are now starting to do just not this interesting a couple of patients a day, but serving thousands and thousands of patients. And we're seeing insurance companies that are suddenly getting in the game. All of a sudden, we're having insurance companies offering healthcare services. So we have this whole variety of things that are moving and changing healthcare. And I think it's important if we have 3 people come up on stage now who can talk a little bit about what's happening in the healthcare world. So, boy, if we can get to, there we go. And we got 3 people who I consider are the leaders in the country in some of this change. And I want to just find out from them their own perspective on what's happening. So Roy is here from American Well, and I want to start with you and then move down to Joe Peterson from Specialists on Call and Andrew Watson from UPMC. These are the three people who I consider are three of the leaders of this new change in the new world of healthcare, and certainly in the new world of telemedicine. So Roy, tell me a little bit about American Well and kind of where you guys have been and where you're going.
Well, we're going out in Bourbon Street tonight, but we're a Boston-based company, a technology company. For the most part, we develop software, and it happens to be that software is really large telehealth infrastructures. What we do is we connect patients with available physicians, whether it is their physicians or whether these are physicians that are available somewhere within the state where that patient lives. And for the most part, we've been in the business for about 6 years. We've been very fortunate to do this primarily from the payer angle. We introduced our telehealth services through the large regional and national payers. And we've been very fortunate in the last 12 months to, experience firsthand this incredible tidal wave that's happening in front of us.
So what happens actually when the patient uses your service or uses your technology?
Well, for the most part, patients can be introduced into the technology in one of two ways. They can be given that technology by their health insurance company, sometimes by their employers, where they get health benefits from, and they're told, these are your credentials. You can go on the web or you can go on the phone whenever you need to speak or get in front of a physician, and the system will come back and show to you these are the available providers from your network, the same people that you would otherwise schedule an appointment with, and these are immediate availabilities. You click on connect and you see that provider and they see your record and they can prescribe and everything else. The second way in which patients are introduced is where their physician actually, primary care physician, family practitioner, whoever they are actually advising them when they're in the office, we need to follow up with you regularly, but for whatever reason, either it needs to be very frequent or you live far or you have difficulty leaving your home, we're going to do the next couple of follow-ups without requiring you to ever step out of your house. And then these are scheduled telehealth encounters between the patient and their physician. Either way, we see this being adopted, literally around the country, and many misconceptions or ideas that we thought about rural area adoption versus urban adoption and everything else, all of these have been thrown out the window.
Yeah.
Totally
So give me some idea of numbers.
Some ideas of numbers.
Because we all banter around, is this thing 1,000 or 2,000 people, or what is it
No. These are. It depends on the client, that we have, and we can't name them. This is their business. We are the oracle under the hood, but it's between tens of thousands and hundreds of thousands.
Yeah.
And it really differs by the model of introduction. We've found we like to think that our technology is great, but like most behavioral changes in how things are done, it is really more about how it is communicated to patients and what's the message behind it. Is it something that's going to give you convenience because it's immediately available? Or is it something that's going to give you a whole different kind of perspective of healthcare because you now have live healthcare in your medicine cabinet? Preventive medicine, follow-up, compliance with medical regimen. I mean, there's so many dimensions that come into play, and they affect the numbers at the end of the day.
So, but you're a direct-to-consumer, but kind of through a secondary or third party that's facilitating. Is that fair?
That's fair. I mean, we are playing with the idea of being completely direct to consumer, but we have to respect that this is healthcare is a very traditional market, a very conservative market. I think everybody here probably agrees with that, and you have to pick your wars. And if I came out and put a billboard in downtown Boston saying, here's a cheap way to get in front of a doctor, I don't think it's going to work very well.
Yeah.
So even though Boston people are very open-minded, so the reality is that you have to respect that there is a way healthcare has been done for so many years, and if we're going to introduce technologies that are going to revolutionize it, we need to be respectful to where we operate and where we come from. there are right ways and wrong ways, and that's going to be the make or break of many other companies and many other folks here who are trying to do tremendous things with telehealth.
Yeah. Okay. Thanks. Joe Peterson, specialist on call. Talk to me about specialists on call. What do you guys do?
Sure. We surprisingly do exactly what the name says. We provide specialist physicians on an on-call or really on an on-demand or unscheduled basis to suburban and urban adult acute care hospitals today. So today we provide neurology consultations, we do psychiatry and behavioral health consultations, and now we do intensivist consultations.
And how do you say when you do that, how does that done? What is your relationship with the hospital?
You know, effectively, if there was a whiteboard, I'd probably draw 3 circles on it. Then the left circle would be our clients. For them, we represent an alternative to either paying a stipend to local physicians or not having call. And they buy the service because having our on-call resource is to their financial benefit. In the center, I draw a call center, which is really what our operation pivots around, that's staffed by people called consult coordinators, and they really move the physicians around. And on the right-hand circle, I draw today about 75 independently contracted, very high-end physicians that work for us in dedicated 8-hour shifts that provide those consults.
Interesting. So what's your numbers? Give me some idea. What are we talking about in terms of number of patients?
You know, across those specialties, I guess today, some numbers that we had to learn some lessons to deliver. We have a guaranteed 15-minute response time that we don't miss, and it's been a bit of a trick to learn how to do that. We'll do about, we just crested 50,000 consultations. We'll do just about 30,000 this year alone, and that's across about 200, by the end of the year, about 245 hospital clients. So that's kind of, and we're growing probably 70% per year. So it's you know, and adoption has really changed tremendously in the last 5 years. When we were kicking around bringing in a sum total experience of 6 hospitals to a potential new client, that was a very different discussion than we're having today.
So both you and Roy are kind of the outsiders working in a traditional market. It must be kind of an interesting way to try to convince the CEO and the medical director to use your services, or at least not to oppose your services when you come into some of these folks.
Well, unfortunately, we have to persuade way more than the CEO. I mean, between the payers and the employers and the medical boards and the regulators and the physicians and the patient's proxies, and I can go on and on and on. All of these have to agree at the same time that this is a good thing. Otherwise, it won't work. That's where the combinatorics of doing telehealth comes into play. It's a challenge, but it's a lot of fun when it happens.
So, Andrew, we've talked to both these guys who are kind of on the outside. You're more of the inside guy, but kind of an outsider within the inside at UPMC. You've got University of Pittsburgh Medical Center has got a huge program, and yet you're the guy who is on the inside trying to create change.
Well, it's an interesting era, and it's a pleasure to be here. And I will say that I am a specialist, and I'm not on call, and I'm happy not to be on call. So, and also not going to Bourbon Street like Roy. The UPMC is an interesting company in that we started with 2 hospitals in the 1980s, and now have 22 hospitals and 400 care locations, and about $10 billion right now. And we have almost 3,000 fully employed physicians as well. And it's amazing to watch the growth of a very large delivery system in Pennsylvania, which is a very rural state. And we also have, we think, the 2nd oldest population by county. And if you ever drive in Pennsylvania and Pittsburgh, you'll see that very obviously. But it's amazing that the organization also has put a payer arm with our provider arm. And so we have an integrated system. So we have a health plan with 1.9 million members, and is a significant part of the risk-bearing entity of UPMC. And so right now, what we're trying to do as a company is to look at ways to use the payer side and the provider side together. And in terms of cultural change, there's a significant change there because, to Roy's point, new models of care, web-based portals, video at home, and to what Joe's saying too is leverage your specialists. We have specialists, and we have a lot of them. And how do you put specialists into the cloud? But what we're realizing as a company in general is that you can optimize fee for service and optimize the delivery network through telehealth and telemedicine. But the big power that we believe is actually virtualizing a company that's integrated like UPMC. Is how do you actually reach out using the tools of a payer arm, a provider arm, and also using our IT. And we have about $1.5 billion invested in our IT, and let's use it. So we're changing our color, so to speak. We're changing into a different organization where the focus on bricks, mortar, and physician is going into the cloud. And we realize that 95% of the time our consumers are at home or work. And we don't offer a $3 trillion industry, which is healthcare at home or work. And we're also realizing that the currency of healthcare, which is a face-to-face visit, was invented by Hippocrates in 200 BC. And he was put in jail for that as a reward for 20 years. And so that model has to go, because I don't think any of us took a horse to this conference, and I haven't bought a roll of stamps in many, many years, and I don't write letters anymore. So the world is moving very quickly. The consumer electronics market has thrown us a lifeline, and so we believe that this future in the cloud is very powerful. It's what our consumers want, it's what our business needs, and that we have the capacity to do it. And the cultural change is a big challenge.
So you've got a unique cultural change right now in Pittsburgh, because the stories about UPMC and Highmark are legion, I think, right now, and the competition that you're getting from, those of you who don't know, of all things, from an insurer who's actually now in the market of providing health care.
Well, it's a new world order, so to speak, and this will at some point go down like an Icelandic saga. But the bottom line is that an insurance industry is purchasing hospitals to create a competing integrated delivery network like UPMC. And we support integrated delivery networks, but it leads to competition and new models of care, new ways of thinking about how we run our company. And it's a spirited debate, shall we say, and it's a healthy debate, but also it's going to show us what the future of healthcare is like in the cloud. And it's a great opportunity for all of us to learn.
So it's not surprising then, Roy, that some of your big clients are actually insurers, not hospitals.
Well, I mean, we made that bet 5 or 6 years ago, and the reason, in the spirit of transparency, the reason for that was twofold. One is we knew that we needed to get patients and physicians together. We knew that we were too small to get them together, so the only entity in this country that actually brings them together is the payer. I mean, they have a membership on one side and they have provider networks. So we created the system, gave it to the payer, hoping that the payer will do the magic. They will put the magic thing into it, cook it, and something great is going to come out of it. And I think we were right, but I think we underestimated how long it takes for a behemoth like a payer to actually mobilize. And it really took, in some cases, 5 years for the payer to escalate or proliferate the notion that they actually have telehealth capabilities and they can do wonderful things with it. For some reason or another, this year is the year where the big payers got it. Yeah. I don't know why. Yeah. The second reason, admittedly, 5 years ago was that, well, that's where the money is. And as a company, you have to also take that a little bit into consideration.
Just a little bit.
Just a little bit, if you want to be viable. But it was, and maybe just one thing that also needs to be stated. We all understand that the biggest challenge that we're facing is not so much technology. It's really about education and reverse demonizing of this entire thing of healthcare through technology. The people that are going to make the change beyond those entrepreneurial CEOs of health plans and delivery systems are going to be the legislators, are going to be the state medical boards, are going to be the Congress and everybody else. For good reasons or bad reasons, the only way that you will make yourself heard in Capitol Hill is if you have a giant like a WellPoint or United or an Aetna bringing you into the office of the people that make that policy. And that's the way the world works, and you just have to accept that.
But Roy, in many ways, I think that and I agree with you, the legislators at the states and a lot of the policymakers are waiting for the proof points. And I think that we have a lot of pilots and scalability that we're seeing in many sectors, but they want to see these large risk-bearing entities, especially on the commercial side, to show them the way in many ways. Because as you said, the payers are the risk-bearing entities right now. And so Joe and myself and also the hospital businesses, we're starting to become risk-bearing entities of healthcare. And I think that people are waiting for us to show them a very clear pathway in that regards.
No doubt. I mean, your role is pivotal. We can deliver technology, we can do a lot of different things, but unless you get in front of everybody and say, we believe that this needs to be part of the way we operate, the legislators will not do anything. You're right.
I think as an industry group as well, I think everybody that advances a telemedicine initiative that gets to a patient directly or indirectly is part of a wave that needs to happen. It's fascinating for us to be in so many hospitals and both signing new hospitals and bringing new services to existing clients, because the people who are closest to the point of care, the patients, the nurses, the families, they've accepted it, they've embraced it, they know that telemedicine brings them all sorts of things. And as you get further away from the point of care and more towards the carpeted parts of the hospital, that's where you find less knowledge, more resistance to change, and more resistance to telemedicine as a viable solution. And I think we have to keep pushing on demonstrating that it's a viable patient care solution.
So what do you say when you go into those carpeted offices to try to change their minds?
You know, we don't have the ability to consolidate data, to do actuarial studies, to bring our conclusions home, but we have a lot of other interesting data. We'll see just about 30,000 patients this year. Every one of those patients will get a survey for satisfaction and comments on the service, and about 12,000 will send them back. So we're kind of racking up consumer and patient comments on how this service works and how much they like it. Now they'll do it on video, and that's even more compelling. And we can bring these now to hospital administrators and say, look, this is what the patients say. Now this is what the nurses say, and now this is what the doctors say. So we don't have the ability to consolidate the actuarial data, but we do have, albeit somewhat qualitative, we got a lot of qualitative data from the people actually delivering the care that say, this is just fine. We've come a long ways from, I think I took over the company in 2007, and the first thing that someone said to me was, oh, you are the guys with the neurologist on a stick. And that was the physician reception to telemedicine, and we've come a long way since then.
Neurologist on a stick, I love that.
Hey, John, one question and one comment. And I actually don't know what the point of care is anymore. And I grew up in a family of surgeons, and I do colorectal surgery right now, and I still practice surgery, and I won't do it here on stage, so you're safe. So I don't know what that's right.
I feel like a little uncomfortable myself, thank you.
Actually, Chucky volunteered over there, we'll see. He had some ideas. He's in on it, okay. I don't know what the point of care is right now, and I don't understand what the point of care is, and I'm starting to question that, because the point of care traditionally was based in and I'm not challenging, I'm just saying I'm trying to figure this out, and I think that we are as well, that this concept of coming to my office or going to the ER or going into a hospital is something of the past. And I think that also, Roy, to your point, that the medical boards view the point of care as being very traditional again, and this is based in 200 BC. So we need to challenge the point of care and push it out there, because the point of care is going to be in the cloud where our consumers are. And I think it's a debate that we have to have, and actually we need to formulate a position as an organization saying the point of care is not hospital-based, it's not office-based, and it will be cloud-based or virtual, or find a word that's palatable to whoever needs to hear it. But the E strategy begs the question that the point of care is out there, and it's just not where we think it is right now. And I struggle with this, and I think that many organizations do as well.
You know, I think, just, maybe 2 cents here. I think the challenge of saying the point of care is not what it used to be, I think it's a very valid point. I just think it's a very risky point, because it's too transformative. You're putting a question mark on something that people have been living with for hundreds of years, as you said. I think the one thing, you asked, what do we say when we walk into those badly carpeted offices? So the one thing that we say very simply is that telehealth and telemedicine is a channel of care delivery. It's a pipe, it's a conduit for care delivery. And everybody out there that is responsible for regulating the practice of medicine should focus on the practice itself rather than on the conduit in which it is delivered. Physicians have the discretion to decide, based on what's in front of them, whether they can do this for the patient or that for the patient. That happens irrespective of telehealth. If I walk into my physician office with whom I have a long-lasting physician-patient relationship, and I'm in person and I say, hey doc, I would like to get some Percocet. And the doctor would say, sure Roy, I know you for years, I'm going to give you a prescription. This is horrible medicine. It's in person. He can examine me to the wazoo if that's what he wants, but it's bad practice. All of those authorities that deal with the good practice of medicine should focus on what medicine is delivered, not on the way by which it is delivered. And what we represent here is efficiency and of the conduit. We allow physicians who are available to get to patients who otherwise don't have access. We allow to bring healthcare into the homes of people who would otherwise not leave. We allow productivity and presenteeism to change. Don't kill the messenger and the technology. Figure out what is safe medicine through that technology. And when we walk into state medical boards or legislators and talk to them, and we make that point, that for as long as you see this as a conduit, you preserve the physician discretion, and you continue, like you usually do, regulate the quality of care that that physician gives, that's okay. And I don't know what the point of care is, but I don't think it will ever be defined. I think it's going to continue to morph as we go forward.
Agree.
So looking forward, I'm curious of the three. Within ATA, we have traditionally said since the beginning, in terms of our work on public policy or to working to try to deploy telemedicine, people say, eliminate the barriers to telemedicine. And the number one barrier I used to hear all the time, reimbursement. Reimbursement, reimbursement. We got to get Medicare reimbursement, because if we don't get Medicare reimbursement, telemedicine's going nowhere. Well, I've just heard some amazing numbers out of you guys, and I don't think you guys are getting fully reimbursed out of Medicare right now. So I'm just curious. I know a little bit about how you did that, but I'm not sure in terms of moving forward what you would see as your barriers as you move ahead.
Well, reimbursement is a huge deal. The good thing is that, when we're here on this stage in 2012, the reality on reimbursement has dramatically changed from even 2011 to 2010. Interestingly enough, some of the largest payers have either announced or are in the process of announcing in the very immediate future coverage for telehealth. They will reimburse physicians for seeing patients through technology. They have certain criteria about what the technology has to have. It needs to be beyond telephonic and whatever it is, properly documented, but they will reimburse for this. And this is a paradoxical statement, I'm sure, but the good thing is that healthcare is, for the most part, bankrupt. I mean, we have our back against the wall, and interestingly enough, often when your back is against the wall, great things happen. And maybe the best example is Medicaid, the smaller part of what CMS is doing. Medicaid has actually gone much, much further than Medicare in terms of accepting and reimbursing for telehealth. I mean, 30 states have already stated this year that they will reimburse for telehealth as a way to deliver care. Each state has its own flavor, but the reality is that between the states, the VA has gone and removed copay for telehealth. Not only that they cover telehealth, they are creating, incentivation for patients to take advantage of telehealth. Reimbursement is changing. And as we've had a conversation many times, I think the challenge of reimbursement is going to go away. It's about education. I don't know how many of you here in the audience know the difference between telemedicine and telehealth. We are the authority here. I mean, we are the captive audience. We need to create some clarity about what we can do and about how we're going to do it, and reimbursement will follow.
I think that's right. I will tell you that certainly when it comes to specialist physicians, and that, which is a large part of, it's obviously, it's a large part of what we do, and in fact it's all of what we do, but it is a large part of the application of telemedicine. I think that game is still yet to be defined. I think it will be surprising if in my biological lifetime, reimbursement for specialty telemedicine is actually sufficient to cover the cost of delivering it. And I think that's always going to have to be a blended model where other parties at risk, and I think you're going to see a shakeout. You're going to see consolidated systems like UPMC that are leveraging lessons that are learned in telemedicine in bringing efficiency within their system. And I think you're going to see large payer entities able to leverage it as well. And there's going to be kind of a third nation. It's almost the white space in between all of those that are a lot of hospitals and a lot of patients where it's still going to have to be some combination of the local provider along with the payer to fund that telemedicine. But I think all of this, I think you're never going to live the Bourbon Street comment down. So if we followed Roy down to Bourbon Street, which is apparently where he hangs out, which is what he said earlier.
Every day.
Every day.
I asked if I could come with beads rather than time.
That's right.
Roy, can you expense that?
I'll figure that out by the end of the conference.
Yeah, that's right. But I think you'd sit down across the table with a 36-inch drink and hear a lot of comments about lessons learned. And I think that's why the ATA is so important. I'm sorry, I don't mean to give you a plug, but I think it is. I think that's why this gathering being this size is being very important. We all have current perspectives, and but boy, I think we'd all agree that we learned a lot over the last 5 years, and it looks very different than it did when we started out 5 years ago. And I do think a lot of these questions are going to get defined by us and everybody that is trying to advance this by continuing to push and continuing to push. I think things like, and I speak with a degree of self-interest here, but I think things like a forum for people that directly provide patient care, which the ATA is putting together, I think it's going to be very important because we need to consolidate these lessons to really equip large efforts, small efforts to make progress. And Roy and I were standing backstage, and we got talking about who has whom as a competitor and otherwise, and he made a comment that I think is very true. It's a huge landscape. It's a huge marketplace, and I think the more that we amass for everyone's access, whether it's in their institution or their business or otherwise, the lessons that we're using to learn to push the edge of the envelope forward, I think the more we'll figure out what the answers are. And there's a lot of room for everyone to run.
So Andrew, where do you see the barriers for UPMC?
Is it okay if I run with scissors for a little while? I don't believe that reimbursement is the barrier. I believe cultural change is the barrier, and that when I was trained, they gave me a scalpel, and my grandfather said, if you can't see, you can't sew, cut them open. And then I now use chopsticks and video cameras to actually work with my patients. And I've taken my length of stay from 14 days down to 2.5 days. I've transfused one patient since 2007. I haven't had a leak from a bowel anastomosis in 26 months right now. And I don't draw labs in any of my patients, and I save 9 nursing encounters per day per patient by being a little bit savvy about this with my peers. And we've been through this before. As an industry, we saw laparoscopy and what it did to a whole subsegment of healthcare specialists. But if you look back at what's happened in the past, I realized that in the late 1800s, the surgeon with the most amount of stool and bile and blood on their coat was the best one, until Lister came and realized that that was the fomite, and that's how people got infected. That's where the clean white coats and hand washing came from. And then we had the whole rise, if you look through what's going on with antibiotics, and my grandfather overseas learned how to use penicillin in World War II. Then we get into transplant and science and understanding genomics. We realized with transplantation, one organ won't fail the organism. Then we got into laparoscopy, EHRs, and now we're hitting the cloud. I think the greatest challenge that we have is the cultural change, the challenge what we're all doing here at this organization. And certainly with Roy and Joe, and certainly with your leadership, John, we're pushing healthcare out there. And that the cultural change is perhaps the greatest one, because it's the consumers that matter, it's the patients. And it's also the people that are buying healthcare, which are the employers, the self-pay, the small businesses. Those folks are purchasing healthcare. And so in that perspective, what they think is more important than what I think a lot of times what we think. And I think the cultural change is the greatest one. So with that being said, new models of care, and you're looking at 2 experts in new models of care, and certainly you're leading the charge, John, that look what Specialists on Call, what American Well is doing. These are new models of care. And we have a new Chief Medical Scientific Officer, Dr. Shapiro, who's now running our physician division, and he firmly believes in new models of care, looking at transitional care, nursing homes, looking at simple ways to do remote monitoring. And so the new models of care, I think, are the most critical, again, begging the question, what is the point of care? And then to answer the question about how we get reimbursed for this, it has to be a gain share model with the payers, in that the payers, through cost avoidance and a number of other different mechanisms, are going to be reaping the benefits from telehealth if done correctly. And so the gain share models, I think as a specialist, are more potent than straightforward reimbursement. And that discussion we have to have on the table at all times with the payers. So I'm very concerned about the cultural change. I think this is perhaps the greatest one, because you're fragmenting the fee-for-service, the face-to-face visit, which is correct. And you're creating, to some degree, a virtual business, which is an export business that the payers are going to devour. And certainly I look at peers of mine in the audience. One of my friends, Paneet's out there, he's looking overseas in India, looking at some of my other colleagues. You realize it's a new world order, and the question is, what is that? What's right for the patients, and how do we guarantee quality? But I think outside is important.
Let me just ask you a question, or you want to say something? Specialists on Call provides specialty services, neurology services into the hospital, psychiatric services, a number of other specialties. So does UPMC. Are Specialists on Call a competitor, or are they an ally?
Who are you asking?
I think you're buying dinner. I think that for the patients, that the whole concept of what's going on, that we're allies, because we have to prove to the consumers, the hospitals, the patients, and the payers, that one of us may have a better product or may have a better service. And so from a business standpoint, they're competitors, absolutely. But it's going to make us be better, faster, leaner, and more effective. So technically speaking, they're competitors. I think to the patients, they're allies.
What do you think, Joe? Now I ask you, Roy.
I think we're getting into a pretty, sort of a pretty micro view of different interfaces that we have with the healthcare system. I think that in the ideal world, we're allies. There really shouldn't be a moment when I can do a better job in an integrated system like UPMC, when I can do a better job in their core hospitals than they can on delivering specialty input and specialty consultation. I think as delivery systems get larger, they all have gaps in coverage that are unwisely filled by their existing resources if those resources are short. I think today, sometimes we're viewed as a competitor because we're really viewed as a competitor in non-owned but aligned facilities.
Yep.
And I think that's going to change over time, because that competition today occurs on the customer service level, not so on the core clinical level. That competition today occurs because it's the other dimension of telemedicine where I do believe we have to kind of step up and be a bit responsible and attentive as well. We are talking about some very elegant concepts, and I'm clearly not as smart as he is. I'm just trying to understand what he says. But, we are also talking about some very grubby concepts like customer service.
Right.
Like, are you making it easy for the nurses to use? And are you being friendly to the patients? And if you say you're going to answer the call in 15 minutes, you answer the call in 15 minutes. I think that as an industry, as those things become more uniform, then you're going to focus more on what's actually just happening clinically.
Roy, you get the last word.
Agreed.
I don't think that we as vendors matter at the end of the day. I think 20 years from now we look back and there's going to be this company and the other company and the other company. What's really going to change the industry is our ability to, in a very agile fashion, change the way we're using telehealth. We haven't even begun to look at it. 3 weeks ago, Allscripts announced that they're going to introduce our telehealth capabilities into their systems. What that means now is that telehealth, which we all thought was a payer thing and a government thing and a large medical center thing, is become part of the ammunition that physicians can use with their own patients, built into their native systems in the office. These are the things that are going to create adoption for telehealth. It's not, we the vendors are not important. We're just the carriers at this period of time of that message, but we have so much more to do, and it's changing in front of our eyes.
Thank you. Thanks to all three of you. I think this is the beginning of a series of dialogues we're going to have, because this whole thing is changing almost so fast we can't keep track of it. And again, thank you three as the three leaders who are really kind of taking this industry, we call it, and putting it in a whole different world. And I want to have everybody applaud and thank you very much for your participation in this.